Hello, today we will finish what we have done last time in this lecture, ribs and pictures and paragraphs, skin and fascia, external intercostal muscle, internal intercostal muscle, intercostalis intimus muscle, lung, pleura, costal groove, neurovascular bundle, vein, artery, nerve, ventral primary ramus, dorsal primary ramus, sympathetic ganglion, muscular branch, external intercostal muscle, internal intercostal muscle, intercostalis intimus, lateral cutaneous branch, anterior cutaneous branch, an intercostal nerve and its branches, the intercostal muscles. As you can be appreciated from the figure, the lower intercostal spaces are much shorter than those between the two ribs above. However, the intercostal nerves do not stop where the intercostal space is closed by the costal cartilage, but carry on across the abdominal wall to supply it. The lower 6 pairs of intercostal nerves carry motor axon to the abdominal muscles and sensory processes from the skin of the abdominal wall and peritoneum lining the abdominal cavity. Clinically related aspects of the intercostal nerves are outlined: pleura fluid, sampling and shingles. Blood, pus, or air may be aspirated from the pleural cavity via a needle inserted between the ribs. If the needle is kept close to the upper border of a rib, the main neurovascular bundle is safe. The needle will displace the smaller branch of nerve and vessels rather than puncturing them. Infection of the dorsal root ganglia by the herpes zoster chickenpox virus leads to a burning pain followed by a rash over the skin, supplied by the intercostal nerves arising from the infected ganglia, a condition known as shingles. The thoracic inlet is the junction of neck and thorax. The boundaries of the inlet are the superior border of the manubrium, the deep border of the first ribs, and the body of T1 posteriorly. Laterally, the thoracic inlet is closed on each side by a dome of dense fascia. The suprapleural membrane covering the cervical dome of the pleura, as already pointed out and illustrated, the lungs and their covering pleura arise above the level of the first rib and about 2.5 centimeters above the medial third of the clavicle. A penetrating wound or the displaced fragments of a fractured clavicle could rupture the pleura, producing a pneumothorax or even damage the lung itself. Structures that pass through the inlet between the thorax and neck lie towards the midline between the lung and their coverings. The diaphragm. The thoracic cavity is separated from the abdominal cavity by a muscular-tendinous sheath. The diaphragm, the aorta, inferior vena cava, esophagus, and vagus nerves are transmitted through apertures in or behind the diaphragm. As shown, the diaphragm has a peripheral muscular part surrounding a central tendon. The striated muscle fibers are attached at one end to the central tendon and at the other end of the lower margin of the thoracic cage. The xiphoid process anteriorly and the lower six costal cartilages laterally also illustrates the posterior attachment of the diaphragm. It is attached posteriorly by muscular slips called crurae to the upper lumbar vertebrae and by arcuate ligaments which are attached to the fascia covering two muscles of the posterior abdominal wall, the psoas and quadratus lumborum muscles. Inferior vena cava, right theorenic nerve, central tendon, median arcuate ligament, aorta, right cross, sympathetic trunk, left phrenic nerve, muscular sling, esophagus, vagus nerves, medial lumbocostal arch, quadratus lumborum, psoas, left cross, central tendon, liver, costo-radiophragmatic recess. Figure an inferior view of the diaphragm and anterior view of the curvatures of the diaphragm. It should be obvious that the anterior attachments of the diaphragm are much higher than the posterior attachments. The diaphragm, therefore, has a curved shape if viewed from the side. When viewed from the front, the diaphragm is a double dome. The right side of the dome tends to be higher than the left side because it overlies the liver, a solid organ. Both domes sit slightly higher than the relatively flat central tendon, which lies at the level of the xiphi-sternum. The lateral attachments are much lower than the attachments in the central tendon, producing a marked curvature of the muscular part of the diaphragm on each side. This produces an acute angle where the diaphragm meets rib, forming a narrow gutter, the costo-diaphragmatic recess. Functions of the diaphragm. The diaphragm is an excellent example of the action of one muscle group affecting the action of others. The diaphragm does not operate alone, but works in concert with the intercostal muscles to alter the dimensions of the thoracic cavity during ventilation. If we consider the movement of the diaphragm in isolation, contraction of the muscle components during inspiration will lower the central tendons towards the lower margin of the thoracic cage. Basically, the shape of the diaphragm will change from a dome to a flatter profile. thus expanding the vertical dimensions of the thoracic cavity. At the same time as the diaphragm is contracting, the intercostal muscles are also contracting, moving the rib cage upwards and outwards. Rib movement elevates the position of the attachment of the diaphragm towards the central tendon, thus tending to flatten the diaphragm. These actions are described in context of ventilation. The most obvious function of the diaphragm is as muscle of ventilation, but it is also used to aid micturition, defecation, and parturition. If you take a deep breath and then close the vocal folds and breathe out, the air will be unable to pass through the larynx and pressure will build up in the thoracic cavity. This will prevent the diaphragm from rising, thus raising the intra-abdominal pressure. Simultaneous contraction of the muscles of the abdominal wall will further increase the intra-abdominal pressure, pushing the bladder, rectum, and uterus to expel their contacts as the specific action requires. Diaphragm openings. The diaphragm has three major apertures through which vessels and nerves pass from thorax to abdomen or vice versa. They are shown with the aortic opening. Transmitting the aorta actually lies behind the diaphragm, between the median arcuate ligaments and the 12 thoracic vertebrae in front. The descending thoracic aorta becomes the abdominal aorta as it passes through the diaphragm. The sympathetic trunks also pass behind the medial arcuate ligaments on each side of the aorta. The esophagus opening is at the level of the T10 and transmit the esophagus and the vagus nerves. A sling of diaphragm muscle surrounds the esophagus opening. This forms a sphincter which plays an important part in the preventing reflux of stomach contacts into the esophagus. The caval opening, transmitting the inferior vena cava, is at the level of the T8, passes through the central tendon to the right of the midline, which maintains the patency of the opening. Its diameter is therefore not reduced by diaphragmic contractions, so venous return to the heart is not impeded. The consequences of weakness of the sphincter are explained. The diaphragmatic hernia in some patients, usually of middle age, the esophagus opening may become weakened and widened, producing a hiatus hernia. In the commonest type, the short abdominal part of the esophagus and the upper part of the stomach rise through the hiatus when the patient lies down or bend over. Unpleasant reflex of acid stomach contents into the esophagus may follow, causing heartburn in the long term. Repeated exposure to acid can cause ulceration of the esophagus mucosa. In persistent cases, the acid reflux can even affect the mucosa of the pharynx and larynx and cause erosion of the dental enamel from the teeth. The mystery of the innervating of the diaphragm. Why is the diaphragm positioned between the thorax and abdomen, innervated by nerves arising in cervical spinal cord and not the thoracicolumbar as would you seem. The reason is due to the embryological origins of the diaphragm. Its embryology is complex, but the important points are that the central tendon develops from the septum transversum. This structure comes to lie at the level of the cervical segments. As the embryo develops a longitudinal curve, the septum transversum is displaced inferiorly as the respiratory tract develops as an outpouching of the thorax that expands out to form the bronchial tree and lungs. The potential central tendon carries with it muscles derived from the cervical myotomes, which will form the muscular part of the diaphragm. These drag their nerve supply, the phrenic nerve, with them as they migrate downward. Nerve supply to the diaphragm. The phrenic nerves carry the motor nerve supply to the dome of the diaphragm. They arise from the ventral rami of cervical spinal nerves 3 and 5. C3, 4, and 5 keeps the diaphragm alive is a rhythm used to be generations of students to recall this information. Their course is described in more detail. The phrenic nerves also carry the sensory supply from the partial pleural covering of the upper surfaces of the diaphragm. The peritoneum covering is lower aspect, the mediastinal pleura adjacent to the heart, and the pericardium surrounding the heart. The reason why the diaphragm receives its innervation from the central nervous cervical spinal nerves is explained. And thank you for listening.